Here we go, guys. Back at it. Chapter 7, Understanding EKG, Introducing Sinus Rhythms. Let's get moving. Different objectives. So, the origin of the sinus rhythm. Each rhythm is classified according to the heart structure in which they begin. So basically their site of origin. So this is primarily where we want, not primarily, but this is where we want, and for normal sinus rhythm, this is where it's going to be paced from, or the site. The problem is sometimes that doesn't work, and you remember we have these backup pacemakers, and all of a sudden now different places are pacing the heart. But in a sinus rhythm, this is going to be the SA node, the sinoatrial node, is going to be the pacemaker or the site of origin for this. So normally, for that normal sinus rhythm or the normal rate that we're looking for, we want 60 to 100. So anything less than would be bradycardic, anything greater than will be tachycardic. So within this area, our the normal rate is going to be between 60 to 100. And that's inherent or intrinsic. So just kind of think of natural, or kind of just the, kind of the way that it's made, this pacemaker site. That's its normal rate. So as long as this rhythm is originated or paced from this SA node, then it's going to be called a sinus rhythm. The way that we know that, if you remember, we look for those P waves. That's one of that's the big requirement for something to be a sinus rhythm, is to have that upright and present P wave. So, components of electrical conduction system of the heart. You guys have gone through this, but we'll revisit it real quick. So the electrical impulse originates here in the SA node, and then it travels. That impulse travels through the internodal pathways, and you can see where those are. That's through here, as well as it comes over here to this other atria. It doesn't have a very good, doesn't do a good job of showing that, detailing that for you, but it also works through this area as well. So that current travels through these internodal pathways, so that current can go to all the way through the heart. Then once it's gone through there, it goes to the AV node, which you see here is the AV node. So it's traveling through these internodal pathways. It comes all the way around, goes to the AV node, and then down through, you get this brief pause through here when it's traveling through here, and then it goes to the bundle of His, which is this next pacemaker site. Then it drops down to your right and left bundle branches, and then into your Purkinje fibers. Now the problem is, we'll just jump ahead for a second, the problem is when this becomes a pacemaker site, and these become pacemaker sites down here, you're going to have all kinds of weird and funky looking rhythms, and it's not going to be very good for your patient. So here's the pathway of that SA node, the internodal pathways, to the AV node, the bundle of His, the bundle branches, the Purkinje network. So we're starting at the top and working our way all the way through the bottom, hitting everything in between, basically. So here's our rates. You are going to need to know this from today forward. SA node intrinsic rate is 60 to 100. Your AV node is 40 to 60, and then your Purkinje network, or essentially ventricular rate, is going to be 20 to 40. So these are things you're going to need to know moving on to be able to interpret EKGs, but as well as because you're going to need to remember certain rules, and these rates apply to those rules. So when we say normal, we kind of think about those rules that we had, and when we talk about normal sinus rhythm, we had those rules, those 5 rules, and basically everything is checked off in the boxes, meaning every single one of those rules is complete and good to go, and the rhythm fits right in there, nice and neat. So all the answers in your 5-step approach must be within normal limits. So we remember what that was, right? You had your rate. You remember what your rate was, 60 to 100. You have your rhythm, whether it's regular. You have your PR interval. You have your QRSs, all of that stuff. So everything is within those normal limits. So normal sinus rhythm, the heart rate falls within 60 to 100 beats, And the atrial and ventricular rhythms are regular. So how would we figure that out? That's a great question. So atrial, we're going to look at our P wave. Ventricular rhythms, we're going to look at our QRSs, right? So each one of those are regular. On every QRS, you have a P wave that precedes it, and the PR interval falls within this normal parameter of 0.12 to 0.20. QRS is less than 0.12 seconds, and so by all of those things being in place, everything is within normal limits, so it is a normal sinus rhythm. Now, you're going to need to know these guys first. You're going to need to know it by memory, and then eventually you're going to understand it and just know it. So you're going to need to remember that the rate is going to be 60 to 100. We're up here talking about normal sinus. So both of your atrial and ventricular rhythms are regular. P wave before, the P waves are upright and uniform. Your PR interval is normal within 0.12 to 0.20 seconds. Your QRSs are, they all do look alike. They're all similar, and they are within the normal limits of 0.12 seconds. So let's look at our, let's go ahead and look at this guy and compare him to our rules. So what is the rate? 60 to 100 is what we expect for a normal sinus rhythm. So this guy's right on here. So 3, 150, 175. So we're looking at about 80. We'll verify it with our 10-second rule. Remember, this is a 6-second, not 10-second, but 6-second strip. We'll multiply that by 10. This guy's kind of right on there. Looks like, you can see he would be really close, but we're not going to count him. 1, 2, 3, 4, 5, 6, 7. So we're 70s, almost 80s. And like I said, we were at what? 3, 150, 175. So between 75 to 80. So I'd say we're good to go there. Our rhythm is regular. So when you go ahead and start doing, looking at your rhythm and your time for each one of these, this appears, when we look first glance at it, it appears to be regular, as well as when you start looking from P wave to P wave or R wave to R wave, and you start marching it out, this is all regular as well. And then P wave before each QRS, I would say that is true. Each one of these have a P wave here. I keep doing that, don't I? And they are all upright and uniform. So these are all upright, meaning above the isoelectric line, that positive. And uniform, yes. What is the length of the PR interval? So we're looking at what, 1, 2, 3 boxes. So we're within normal limits, 0.12 to 0.20, then 3 to 5 small boxes. And QRS complexes look alike, and are they within normal limits as well? They all do look alike, and we're looking at probably, what, 1.5 small boxes. So we're at 0.06, so we're good to go there. So this would be, as listed, a normal sinus rhythm. Hope you all agree. Sinus Brady. Now, the thing to remember with this is, first off, it is a sinus rhythm. So all of those same rules apply. The only difference is going to be that it is bradycardic. So that is going to be less than what number? 60. Less than 60 means that it's going to be bradycardic in this rhythm. So rhythm may resemble a normal sinus, except that the heart rate is slow. The SA node discharges and pulses at a rate less than 60, and that's really the only thing that makes this different or an abnormal rhythm. So there's a lot of different things that can cause this. Vomiting because of the pressure that's placed upon the vagus nerve. Hypoxia can. Hypothermia. Electrolyte imbalances. Obviously, certain drugs, beta blockers are for sure, calcium channel blockers, they're for sure going to slow things down. As well as down here, you see this normal phenomenon. I don't know that you'd call it a phenomenon, but well-conditioned athletes or people just who are in good shape, they may sit around in the 50s and 55 without any problem. One of my paramedic instructors was a marathon runner, and he was typically in the 40s, so which is quite normal for someone who goes out and runs all day long. So really, we talked about the main difference is going to be that rate. So the rate is going to be less than 60. Everything else is going to be the same. So let's take a look at our rate. for this 6-second strip, when we multiply that by 10, we know we get 40 here. But let's go ahead and do this other rule. So 300, 150, 1, 75, 60, 50, 40. So we're right around 40, right? Did I do that right? I think I did. 3, 150, 1, 75, 60, 50, 40. Yeah. So we're right around 40, a little less than 40. And everything else, once again, is still. So our P wave is still upright. Our PR interval is still within the normal limits. Our QRSs are all similar. They're all within the normal limits as well. And everything is regular as well. I think I skipped that, but everything is regular. Sinus tach. Once again, it's all the same stuff. Sinus, everything is still going to be the same. Difference is this guy here, tachycardia, so a fast heart. So tachycardia, fast heart. Still originates in the SA node, only difference is the rate, somewhere between 1 and 160. This is something going to be important to remember because there is a time when this number becomes very important. When we go above 160, as you'll find out when we get to atrial rhythms, we're going to go into another rhythm. Nothing else changes other than the rate. So it's going to be very important that you remember 100 to 160 for sinus tach. So a lot of different things can cause this as well. Exercise, obviously. Fear gets that adrenaline going. Stress does as well. Pain, anxiety. Ingestion of stimulants or coffee also does that as well. They have some effects upon your cardiac muscle. And then we know that hypovolemia, CHF, all these kind of compensatory mechanisms can cause the heart to beat at a faster rate as well. So you see everything else is once again all within the same parameters as before. It's just this 1 to 160. That's going to be the key. So let's go ahead and take a look here. We'll just jump off on this guy. He's right on the dark line. 3, 150. That's going to be 1. So we're looking at about 125. Do you agree? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So in the 120s, just to kind of verify it. P waves, they are upright and they are present for each and every QRS. Our PR intervals within normal limits. When we look at that, when we measure it out, our QRS, they're all very similar, as well as our width is good, our time is good. And for whatever reason, I keep forgetting to get the rhythm right after rate, but it does appear when we first glance at it that it's going to be regular as well. But when we march it out, and we can march it out on P waves or QRSs, to me it's just easier to do on your R wave. Then we march that out, and these guys are all the same as well. Remember, we're making a little tick mark, a little mark on a piece of paper like this, and then we're just going to shift it down the paper as we go. So sinus dysrhythmia, same as sinus rhythm, normal sinus rhythm, except for a slight irregularity of the heart rhythm. Sometimes you can pick this up, sometimes you can't because it is pretty slight. The rate of impulse formation in the SA node may vary with respirations. So as people are breathing in and out, deep breaths, that can actually cause within the pressure changes in the heart and things, it's causing it to slow down or to speed back up. So one thing that you'll see is this P to P and R to R intervals change with respirations. So by doing that, we know that when we look from P to P wave or R to R wave, we're looking for rhythm, right? We're looking for regularity. We see that increases with inspiration and decreases with expiration. So you should find a difference of at least 0.8 seconds between the shortest and longest R to R intervals. That was going to be what? About 2 boxes. So we can see a couple of different things here that can cause it. Sinus dysrhythmia, main thing, it's going to still be within the rate, but the rhythm is irregular. Everything is still the same though, right? For it to be sinus, we've got to have that upright and present P wave. So we know that all of these things are still within normal limits. It's just the rhythm is irregular. So let's take a look at this. Now you see when you first glance, you may not kind of pick it up, but as we move down here, when you march this thing out, you see looks a little bit widened here as well as a little bit shortened here. So remember, when we talk about varying with respirations, increases with inspiration and decreases with expiration. So we see a shortened R to R here, We also see some lengthening going on here because you can see the difference here. So once again, mark these things out, march them out all the way down, and you'll see that this guy is going to be right around here, you know, and you just move on down. Sinus arrest. SA node fails to initiate an impulse, so all of a sudden it just decides to skip, kind of like some of you guys decide to skip class or to log in onto the LMS. Well, that's kind of what the heart's doing, which is a little bit probably more important than somebody skipping class. But absence of PQRST complex is noted, so you're going to have just this blank spot, right? Slight period of cardiac standstill. Now that sounds a little bit menacing, doesn't it? Cardiac standstill. The heart is not doing anything. It's just standing still. So what happens is then the sinus node continues and it fires back up and it picks up right where it left off. Not necessarily within the rhythm and the regularity. It's not going to pick up all the time of where the next beat should be, but it just picks up and then continues on where it's supposed to be doing. So a lot of things can cause that. Hypoxia, ischemia, which we know these are two big things. Damage to the SA node, whether that's through an MI or whatever, some different meds. I've personally, I don't think that I've seen this. If I had, I wasn't paying enough attention to recognize it. Sometimes you'll have a period of that cardiac standstill, but the times that I've recognized it was drug-induced, so it was because we gave them a particular medicine. Now, the main thing here, you see patient assessment is imperative. We always, as we talked, we always want to match our patient with our monitor. So it's no reason to freak out if they have this little period of cardiac standstill, this little sinus arrest, but everything's still going on. Color's still good. Maybe they're even alert and oriented and talking to you because it's just for a split second. So we wouldn't expect that all the output is going to go away and the brain is not going to be getting perfused. Everything is still working. It's just for a second we missed a beat. So we want to make sure we do a good assessment. So what is the rate? That's variable. It depends on the frequency of the sinus arrest. And then obviously it's going to be irregular. But once again, it's sinus arrest, so we do have a P wave and it's present and it's upright and it's to every QRS and all of those things. When we do have it, these are all within normal limits. So there you go. So everything's clicking along. Hey, Miss Johnson, blah, blah, blah. Whoop, there she goes. Now, she might get a little glazed look in her eye, or her eyes kind of roll back in her head, or whatever, but it's just going to be for a split second. A good sternal rub a lot of times is what will help somebody out. That brings them around sometimes. But you see, just picked right up where she left off and just kept on trucking. So let's talk about some significance. That's really the big thing. So just because someone's heart is beating slow doesn't mean they need atropine. Just because it's beating fast doesn't mean they need cardioverted or adenocard. Sorry. We want to go ahead and do a good assessment and make sure that they need us to intervene. So the things that we look for, and this is going to be true from now on, you need to remember this. If they are experiencing chest pain, let's say this. They had a heart rate at 44 and they're experiencing these symptoms. Chest pain, dizziness, weakness, fainting, decreased blood pressure, altered LOC. You see that this is what's going to be symptomatic or unstable. So now it's become relevant because what we're reading here is they have a decreased cardiac output, right? So that's why it has now become relevant. Just because they have a heart rate in the 40s doesn't mean anything. As long as they're pink, warm, and dry and have a good blood pressure and they're asymptomatic, they're good to go. But when they have a slow beating heart or a fast beating heart or even just a normal rate and they start to have these symptoms, chest pains, dizziness, weakness, these are symptomatic. So remember when we talked about atropine and when we used it, you guys think back because you're going to start seeing all this stuff now. So it's time to get those drug cards out. We start talking about using it for unstable bradycardia or symptomatic bradycardia. That's what we're talking here. So someone has a low heart rate and they're dizzy and they're weak and they got some chest pain as well or a bad blood pressure. That's symptomatic bradycardia. So bradycardia, heart rate falls significantly, cardiac compromise may occur. So symptomatic, signs of decreased cardiac output. So what do we do for them? Well, we know we go ahead and put them on some O2. We give them go ahead and throw in an IV. And then if they are symptomatic, we're going to go ahead and give them atropine. You need to review your dosages. Or TCP, transcutaneous pacing. So we're going to do a little electrical therapy on them. Sinus tachycardia. So output may fall when the heart rate is greater than 150 due to inadequate ventricular filling time, or less than 150. That's less than, I'm sorry. So the heart is beating, maybe could potentially be beating so fast that it's not able to fill up properly and able to get the correct amount of cardiac output. So what happens within this is the myocardial oxygen demand increases. You get a lot of things going on with that. So the muscle is needing more O2 and maybe it's getting less. So it can cause some ischemia or even an infarct. Treatment aimed at finding and treating the cause. Now, if they're symptomatic, we're going to do something different than just trying to find and treat the cause. I mean, we're going to treat the cause. We're going to potentially give them some medicine or give them some electricity or something like that. And then dysrhythmia, normal alteration in the heart rhythm. It's especially in young children and elderly adults. So you don't really need to do anything with that. And then sinus arrest, if the patient is asymptomatic, so we're saying they are without that chest pain, dizziness, bad blood pressure, altered LOC. So we're just going to watch them. If the patient is bradycardic and symptomatic, then we may go ahead and do some things, or we are going to go ahead and do some things. Let's take a look at a couple of strips. I'm not going to go through all of these because you have all of these strips and you need to make sure that you do them. So I don't want to steal you guys' fun here. But you also have assignments on the LMS as well, on NEO. So number 1, rate. Let's take a look at that here. We'll start right here. 3, 150, 175, probably about 70. Rhythm appears to be regular. You can do the math between these guys if you choose to. 5, 10, 15, 20, about 22. 5, 10, 15, 20, 21, right around there. You can see that it just keeps going. You can march them out as well. QRSs, they are similar. They're also within normal limits. We're looking at 2 boxes. PR interval is within normal limits. We see that is going to be 1, 2, 3, 4 boxes. Interpretation looks like a sinus rhythm to me. Normal sinus rhythm. So you could put NSR, something you'll see, or sinus rhythm, or just normal sinus rhythm. Well, right away, this guy stands out, doesn't he? Because he's a little bit faster. He also got some weird marking. It's kind of dark, and it's a really tall R wave. So it makes it a little easier, though, because now we can see a little better. So let's go ahead and look at the rate. 3, 150, here's 1. So we're looking at probably about 120, maybe. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, right around in there. Rhythm, it appears to be regular, as well as, let's go ahead and take a look. We got 1, 2, we got 3 big boxes. 1, 2, 3 big boxes. It's starting right before it, so 1, 2, and it's ending right before it, so 3 big boxes, pretty regular. P wave, they are upright and present. PR interval is 1, 2, 3, maybe 4, 3.5 to 4 boxes. QRS complex, at this rate, it's going to be very narrow, but we're not concerned about narrow. We're concerned, number 1, about them being similar, and number 2, we're concerned about how wide they are, to make sure they're not too wide. So we're at basically, looks like 1, maybe 1.5 boxes here. So, and then interpretation, looks like sinus tach to me. Take a look at another one. So, rate is going to be 3, 150, 175, 60. Here's 50, so in the mid 50s, probably 1, 2, 3, 4, 5, and we've got one right here, so we're in the mid 50s. Rhythm, 1, 2, 3, 4, 5.5 big boxes. Looks like 1, 2, 3, 4, 5.5 big boxes. So it looks pretty regular. P waves are 1 to 1, 1 prior to each QRS, and they are upright. PR interval, let's see, 1, 2, 3, 4. So we're within normal limits there. QRS complexes are all similar and they're all within normal limits. I'd say we're looking at sinus Brady. So hopefully you guys see what we're doing here. Remember, your book has your answers in the back for the questions in your book. You're going to need to fill in all of those blanks on the assignment, though, so that way I can see that you're doing this right. I cannot stress how important it is that you guys stay on top of this, because this will sneak up on you. If you're waiting, as some of you do, till the end to work on this, you're going to get lost and just left behind. So make sure you're putting in the time. Ask questions, emails, videos, whatever we need to do. There's lots and lots of good YouTube stuff out there that explain it different, maybe better. So go out and find some stuff also. So next time we'll be talking about some atrial rhythms, and we will talk again soon.